Thanks so much for coming. And in a bit, I'm just going to hand over to our colleagues from Next who've undertaken this independent review for us. What I would say is this isn't the answer to everything. So if you've come along expecting a nice little package for how we're going to get 24/7 guidance and telephone advice across the region, that's not what we've got to deliver. What we've got is an overview of where we are now, what the difficulties are, and a lot of the underpinning factors that need to be addressed. All of our systems are in different places on this journey. There's different challenges, there's different populations. So each system is going to have to make a whole set of decisions around where they go with this information and what they do. The network are really keen to support, as are our clinical leads. As most people know, if you're not from NHS England, we are going through a period of change within NHS England. So we're still a little bit unsure about how things are going to land. For those of us who are in NHS England, I know you'll only be too well aware of that, and we just have to keep plowing on. One of the biggest things that came up through this, and I don't think it'll be a surprise, are issues around things like the digital enablers that we need to get services working together. There's lots of work in that space. Again, it's difficult, different places. There's lots of issues there around hospice provision. We know that the NHS currently and our VCS partners are facing some of the most difficult times they ever have in terms of funding. So we've got huge amounts of challenges, but there's a lot of enthusiasm in the system. And I think what Nick and Simon will tell you is that everybody they met had huge enthusiasm for getting these services right for our families and young people, because they're the most important people in here. So if that's okay, I'm going to pass over now to Nick. Are you doing it?
I am, yes, thank you.
Yeah, brilliant, thank you.
I'm Nick Jones. I'm one of the senior managers in Next Consultancy, and I've led this independent review in conjunction with my colleague Sim, who's here with me today. I think, going back to what Yasmin said, this was to ascertain who provides 24-hour advice and guidance line across the regions. However, I think what became very evident in our initial discussions with Yasmin and Marie et al. Was that we couldn't just have a discussion around the advice and guidance line. It was much wider than that, and inevitably in the interviews that we were going to conduct, that the wider discussion would ensue around gaps in provision, problems, potential solutions, who provides what. And I think it would have been silly of us to lose that wealth of information for each of the systems. So although it was out of the initial scope what we commissioned to deliver, we did say we would reflect that in the report. I think hence the report being so lengthy, and I know it was published last night on the website, which we can point you to at the end if you haven't seen it already. And it is quite lengthy. It is well worth reading, and it does give a wealth of information across every ICB area that we were commissioned to look at. We did form a steering group consisting of ourselves, NHS England, GP rep, patient parent rep, Marie, Yasmin as the SRO for the assignment, and we met fortnightly initially to just look at, was the were we getting the engagement that we needed, was there any problems we were encountering that we could ask Yasmin to support us in. And to be fair, we didn't encounter anything, as Yasmin's alluded to. Every single person was completely engaged, couldn't wait to speak to us, which sometimes people don't want to speak to us, but they did. Some people spoke to us more than once because they wanted to give us as much information as they possibly can, and that just shows how dedicated people are to the development of PLOC in your areas as well. So we did devise a CLOI, which was quite prescribed, albeit we didn't stick to that, I would say, in the interviews, because the discussions were much wider, hence we got the information that we did. We did identify key stakeholders from Yasmin and Marie's perspective at the onset of this assignment. However, we agreed we would probably interview 6 or 7 people. But we built in that capacity to do additional people as well, because we knew people would suggest other people to speak to who they felt was imperative to discuss the patient journey with, and we ended up doing around 53 interviews across a wide, diverse range of roles, from hospice chief executives to PPM consultants, neonatologists, intensivists, nurses, patient parent reps, and everybody gave us the information that we really needed, and allowed us to have a holistic view of the services, opposed to a biased view had we just done clinician only or consultant only. So it is quite a rounded report from everybody's perspective. It was qualitative interviews opposed to quantitative, and again, across a wide range of roles. We did record these interviews, and that was just for our clarity if we wanted to go back and clarify anything afterwards. And we did a thematic analysis, albeit it was over and beyond the actual scope because of the information that we gleaned within these interviews. We extracted the themes from immediately after each interview, and there was a pattern and themes emerging practically from day one. Everybody seemed to have the same issues, and I'm sure probably nationally they'll have the same issues as well, but certainly for us, those themes had emerged, and we'll come on to those later on in the presentation. The findings are there in the report for you to read if you've got a spare hour or so to read it. And each ICB have got their own challenges and opportunities, their own recommendations, but we've also included some economies of scale as well.
Thanks very much. So I can give a brief overview, a deeper dive into our approach to stakeholders, and then just an initial introduction to our findings. So we wanted to gain insights from a range of different stakeholders with a wide range of views, and to understand an accurate picture of services. So as Nick says, we interviewed over 50 stakeholders across this range of roles, with different impact on and different insights into the patient journey. Interviews, as you can see, were conducted across all of the ICBs within the region, and also with those who operate outside of ICS boundaries or are involved in academic research or are NHSE staff. We began with a small number of key stakeholders from each ICS, and then the numbers of interviews expanded depending on where those conversations took us, or when we were directed towards others to gain their insights and to build that holistic picture of service provision. So what did we find? So here's a summary of our key outcomes based on the original scope. You can see the organisations down that left-hand side and the elements around service provision captured for each of those providers. So you can see that 24/7 advice and guidance, a telephone advice line, was not available across all of the ICS, or all of the region, but it was available in some of the ICSs. So that shows us that provision for families and professionals differs, is not equal across all of the region. However, even if it's not 24/7, there is advice and guidance line offered by all of the providers here. There are also there are a number of differing models operating within the North East and Yorkshire, depending upon workforce, resources, or population needs. So as you can tell from the different organisations that are enabling and supporting the phone lines, and whether the provision is medically led or nurse led, would support. So in addition to those findings within our original scope, we also identified those key themes and gaps within the ICS. So Nick is going to give us a brief overview of those things.
Okay. And just in terms of the themes then, I'm not going to labour every single point on the slide because they are contained within the report, but I will pick out the ones that were most topical and appear to be most problematic. I think first and foremost, the interoperability of the IT systems, and I'm sure we all would agree, we've all probably been in the NHS long enough to know that none of them speak to each other. Even I think we've been having these discussions for as far back as I was a nurse on a ward, which goes back quite a few years now. Everybody was using different systems. Some were using system 1, there was PAC, there was EMIS. None of them speak to each other, which did contain massive issues for people and from a governance perspective as well. So just as an example of that, we have one team who support a hospice 40 miles south of where they're based. Out of hours, they can't change a prescription when a child is, needing some symptom management or is quite distressed. They have to contact on-call GPs to write that prescription for them, which again just causes distress for the family, the people who are looking after them, and it is quite time-consuming. Some areas have initiated groups looking at the IT systems, and they have initiated some system of talking for certain areas of systems that do talk to each other, but very much in their infancy, where other places have not done that at all. So I do think that does need to be looked at as an urgent theme, really. Workforce, I think we're all in agreement. We know that there's limited training spaces for PPM grid trainees, and to train them you have to be a grid trained consultant as well. We know nationally that there's minimal numbers of those, so if you haven't got those in your area, then you can't take that trainee and train them. And therefore I think looking at the workforce as a whole, we need to be quite creative around how do we go forward and how do we devise our own call systems, our specialists around these children who need the intervention, because we haven't got those grid trained consultants out there or trainees out there, and it is going to take some time to build those numbers up nationally. In terms of nurses, as Sim's just shown you there is quite a few nurse-led models, and I think we need to invest in their training, their skills and competencies for ANPs, CNSs, not only for their development, but also to retain and recruit these staff, but also to ensure that we have a protracted nurse-led model going forward, because if we don't have that, then this leaves certain areas quite compromised. I think we talked around a lot of the barriers and people that the main one that people raised was around not English speaking. So if you have got that 24-hour advice and guidance line and people are ringing in, how do they do that if they don't speak English? How do they get an interpreter? But not just around those non-English speaking people. It was around our clinical language, and I think we're all here as NHS employees and we know we love an acronym. Everything is acronyms, and I think particularly so when you're a clinician, we inevitably, because it's second nature, we talk in medical jargon, and we just need to ascertain, have people understood that? Are we talking in ways that they can understand what's being told to them? But I think just in terms of some of the barriers, which is not on the slide but in the report, there was other barriers brought out, such as rurality, location of hospices, for examples, deprivation and mental health, lots of things, like a multitude of things to consider. And I think in the recommendations for each ICB is around the consideration of how do we overcome these areas and make sure that we are being equitable to all. And I think just talking about equitability, I think one of the things that did come out loud and clear was the inequities, not only regionally, but against those children who have an oncological disease opposed to non-oncological. And there did seem to be that inequity in service within them, and that is certainly something that needs to be addressed, because everybody should be able to access 24/7 advice and guidance if they need it, regardless of their condition. Primary care engagement, we did interview some GP colleagues, And I think the biggest thing that came out was that they weren't aware of what was out there to support families. Whilst the child was sort of with us, but also when they've passed away, and what support is there for them, for their siblings. And there wasn't anything that they particularly knew. And I think some of the suggestions around that was doing lunch and learn events, and that doesn't just have to be for GP colleagues, it can be for their nursing staff. We could extend that to local authorities, school nurses, etc. So that everywhere one within the patient journey or the sibling journey has access and knows where they can signpost people to for support. Geographical challenges I've briefly touched on there, but again, it's around having that local knowledge. And when we were looking at economies of scale, I think it was raised that sometimes not having that geographical knowledge and the knowledge of how teams and community teams, etc. work can pose difficulties. So we do need to be mindful of this going forward. And when we're looking at our own recommendations per ICB, governance again was a big issue where clinicians felt very comfortable giving other professionals and other clinicians advice and guidance around symptom management, pain control, etc. But when it was families ringing in, they felt a little bit vulnerable. They didn't know how that would be translated, interpreted. So again, some work to do around a governance perspective. Funding complexities, I think we're all aware that hospices receive minimal funding. It's mostly from charitable monies and grants, etc. But again, and I suppose this links to the last point of service specifications, the service specifications across the board, I would not say was robust, and they need to be developed in aligned with national guidance. And some of the services that are offered by specific areas, I think they need to be unpicked, and are they delivering core NHS services that should be funded from an NHS perspective? So I think there is a lot of work to do around that. Some hospitals have, exceptional models, and that's not just within your own localities, but across the country. And there is models that we could emulate, and I think we need to be mindful of that going forward. What can we learn from other areas? What could we replicate? And training models for the future, I think that goes back to the workforce. We know that those places are limited, but then, so how do we overcome this? What other training can we give people to be able to input into this, into PLOC, both from a medical and nursing perspective? I think lack of community paediatric teams came out consistently and from very early on in the interviews. Everybody seems to have robust teams during the day, but come 6:30 at night, everything stops. And then what they're finding is if a child does need that support at end of life, it's based upon goodwill on an ad hoc basis. It's not funded on a permanent basis. And I think we would all agree there probably isn't the demand there to have that team every night of the week. But it's something to consider even from a regional perspective. Could we have a mobile on-call team that can mobilise if and when required, but at least that's commissioned and funded? Because at the moment, by taking people off in hours to out of hours, we robbing Peter to pay Paul, really. So we're not really achieving what we should be. And transition was another big one, and I think certainly from a patient and parent representation, these children, particularly with life-limiting conditions, have had a whole team around them from the day they've been born, and they hit a certain age, and then that's all taken away from them. They feel vulnerable, they don't know who to contact, they then enter the continuing healthcare. It's a very different model in adult provision compared to children, and again, that needs to probably be looked at and commenced much earlier than the transition needs to occur, and then at least then families can be introduced to the adult provision, etc. So that did come out loud and clear. And service specifications, like I've already stated, I think are quite loose and need to be developed based on national guidance, and that people are adhering to that, and everybody's got a consistent spec where possible. Okay, so as I said in the report itself, each ICB area has their own recommendations. Some are quite similar, and some are quite individual to their own areas, as you would expect. But I think we've picked out some of the key cross-system recommendations just as a flavour to give you. So utilise local and national data to demonstrate the impact of hospice activity, utilising a population health management approach, and aligning the delivery of the statutory services with the ICB emergent assurance frameworks. I think what became quite evident, and we were probably sort of halfway through the interviews at this point, was nobody had actually talked to us around the self-assessment toolkit based against the 6 principles of the PLOC National Ambitions framework. So when we probed a little bit further with this, some areas had done it and some areas hadn't, or some areas had done it, but the subsequent actions that needed to follow had not been undertaken or implemented. So we suggested for each ICB to reassess against the toolkit and use those self-assessment outcomes to focus upon their areas of development where they needed to be. And that was across the board in the 4 areas. Undertake the review of those with the barriers, and like I've previously spoken about, not just the language barriers and interpreters, but around those, that rurality, location, mental health, etc., and just make sure that we, you know, everybody is equitable and can access these the services that they need. Offering the lunch and learn events for primary care, and again extend that to our local authorities, social care, school nursing, nurses within primary care as a whole. And certainly to review the paediatric community teams for out-of-hours provision, and it's supported on a permanent basis, albeit, like I just said, it could be a mobile team. And I think, yeah, that needs some discussion in collaboration with more than one ICB, but I think something like that definitely needs to be implemented. And linking with our system partners to improve limited transport linkages. And I know that's not an easy fix, but I think it's something to consider, because it does detract people choosing certain areas for end-of-life provision because they can't get there or they can't afford the public transport, etc. So I think we do need to have some linkages there. The economies of scale. So whilst each ICB's got the recommendations, we have highlighted where we feel economies of scale could be realised, and there is some viable options. There is the capability to collaborate within the systems to provide a more comprehensive model, and that could be across 2 or 3 areas. It could be a tiered rota at a regional level where it is first on call, second on call. That could be inclusive of your ANPs, CNSs, PPM grid trained, gypsies. You know, I think it needs a whole review, and I think people have a wealth of expertise out there, and are we exploring that to the best of our ability? And I think we can do that and ensure that people who are on call are compliant with working time directives, etc., because there was somewhere we thought, you know, that wasn't happening. These are development opportunities for both medics and nursing if we work in collaboration across the board on a it could be on a rotational basis, from acute into hospice and vice versa. A third-party call handler could be utilised within a central model of on-call, and looking at a model further down the country in the south, that's exactly what they offer. Their on-call and their call handling is done via an acute provider, so there is options and there is things that we can consider locally. The Commissioner should review the CCN teams out of hours, that is a must. And for specific areas, additional funding has been requested from specialised commissioning, which would allow them to increase the hours they operate, to increase to 24/7 advice and guidance, and then ensuring compliance with NICE guidance. Next one, Sim. So I think in terms of next steps, utilise a PHM approach within each ICB area. Undertake the service mapping and need within each area. Now, I know some places have done that, some are relatively in their infancy, but I think it needs to take stock of everything. Where are we at this moment in time, and where do we need to be based on this independent review, and how do we get there, and whether that needs some further mapping, etc., to be undertaken. Then if that's what it needs, then that's what needs to happen. Facilitation of some workshops between specific specialist teams and hospices to clearly define service specifications and models of care for the future. I think in some areas it is quite controversial and quite political. But again, I think everybody we interviewed was in agreement that they're there for the benefit of the child and the family. And if that's the case, that we shouldn't have these blurred boundaries. We need to be quite clear around who's delivering what and how and why, and that needs to be defined. And I know that some OD work has already been initiated in certain areas. Collaborate with all of the ICBs to formulate service specifications, adhere international guidance. Some areas have devised an IT data collection tool for their own areas to collate numbers accessing the hospice and accessing advice and guidance lines. What time are they accessing? What is it particularly about? Is it just for reassurance? Is it symptom management, pain control, whatever it may be? But at least then that gives you a wealth of knowledge as well of what people are accessing the lines for. The findings should allow for discussion within each ICB and ultimately commissioner level. And I think the report in itself is a starter for 10 to initiate those discussions. We have done an independent, impartial review, and therefore the findings, you know, they're not biased in any way. And I think it can be used to take the service forward and develop the service. And again, recommendations should be progressed at ICB level, but can be progressed at scale and could potentially be facilitated by NHSE. Just in terms of the review document itself, it was publicised yesterday, so I'm not sure whether everybody's had sight of it. Hopefully some people have. If you haven't, this is the link where you can access that. I'm sure you will all want to read it. So please do. And it is, you know, a starter for 10, like I said, it is independent, it is impartial, and hopefully can be instrumental in development of the services in your localities. Next one, Sim. And I think Yasmin or Marie said at the beginning, obviously the chat and Q&A was disabled. We will enable that now. So if you've got any questions or general feedback, comments, please do so, and we will do our best between us all to answer those. Thank you.
Thanks, Nick. I hope people found that helpful. There's obviously a lot more in the actual report. We didn't want to just go through it page by page. And it's designed so there's a section for each system, as well as some overarching recommendations. So if you want to just look at the system you're working in, that's fine. If you read all through it, it might feel like a bit of duplication because there's a lot of common recommendations. So just be aware of that. I don't know if there's any questions or thoughts that people want to come in with. As we say, you know, as Nick said, it's very much a starting point. We as the network and the clinical leads within the network are really keen to support further discussions, but I also know there's a lot of work ongoing, as Nick said, while the report's being done, systems have been working on it. I can see a hand up, click the wrong button though, so I can't see who it is. Oh, Lewin. Hello, Lewin.
I just wanted to raise a couple of points, and the one is quite a broad point really about the value financially that hospices are bringing to the table compared to other parts of the system, and I think that should be reflected in the share of voice that we have in the decisions that are being made, and I think we are commissioning our own services. So for us at Forget Me Not, where we're only getting 6% of our money from the system, that level of commissioning that we're doing equates to about £2.9 million worth of funds next year. And I know that is a smaller amount than some of the other hospices that are part of this network. So I just think we need to be thinking about that strategically, because there's a whopping amount of resource that can only be directed through collaboration. And if we're going to collaborate, we've got to feel that we are equal partners round the table. And so when you see things in the report, and a perfect example is the out of hours nursing, as you saw from one of the tables that you produced, we're already providing us specifically and a number of the other hospices out of hours support 24/7 that isn't being paid for. So my question, and I keep asking this question and I don't ever seem to get a satisfactory answer, is why would you be thinking about funding stuff that isn't already happening when there is stuff that's happening that you don't fund that you could build on? And I just feel that, to me, that's a really important recommendation from this. And the same applies to transport, actually, because most of the hospices also have access to transport. And that's one of the ways in which we improve access for families to the services that we have to offer, is through having minibuses. And also related to access is the whole thing about interpreter services. So we have access to that. We can instantly turn that on when it's needed. But again, that costs money that nobody's funding. But if you had that service through the NHS, it would be funded. So, you know, there is something here that we've really got to strategically think about, is if we want to make best use of all the resource that we've got, we've also got to think about how we work together and how it's funded and how we truly feel like equal partners, and what we're doing is fully recognised and valued, because I just don't think that it is even now, although I see this as a step forward. I would like to say that. So thank you.
Thanks, Lewin. And I think really, really good point to make. This is about the whole system coming together. It's not about the NHS saying we do this in isolation. It won't work like that. Our health, social care and voluntary sectors partners need to have a joint role in this. Very little of the, or not very little, but a substantial proportion of the care that children and young people and their families get wouldn't be defined as health as well. And drawing an artificial line doesn't always help us. So I think that's, you know, it's a big call on systems to recognise that as well, Lewin. I probably won't suggest we try and broach sorting out the finance here and now, but I think that's a discussion with commissioners as well. I can see Mike's hand. I don't know if Mike was next. Scrolling back up. Yes, Mike.
Thank you. And thank you, Nicola, and everybody who's been involved in this. I kind of welcome a review, and having the independence and oversight of it is also very useful. I think actually Lewin makes a very good point, actually, that there is, but I think broadly it's not just about hospices. There is resource out there in terms of staff and expertise. There's physical resource in terms of buildings and transport and things, and it's happening. To a greater or lesser extent. It's probably happening in not always the most organised way in certain areas, but it's actually happening. So, and I think building the spirit has to be for the region to build on what's good practice already. But also there is a major funding issue, and we've just got to put our hands up and say, you know, and there is a problem here, and we do need to sort of grab that, wrestle with it and try and work out where we want to be. But of course then we've got the opportunity to design actually what does the service look like, and there's no reason in my view that it can't be through different models depending on where the strength of expertise is, as long as it's clear who's funding what and what we get for it, and also what we deliver, then I actually think this can work. But I think Lewin's dead right that actually there's a lot of good stuff out there already, and we've got to make sure we don't undermine that. So that was just a small point. A couple of things in terms of the telephone thing in the northeast. We're already streaming our calls through our telephone service offered for our transport team, critical care transport team, Nectar. So I think those models may be already in place, but you know, whether you can make that super regional, as it were, or across the whole region, I don't know. But I think there are perhaps efficiency areas you could double up on. I'm sure that type of model can work. Although I don't know how well it's working, but it's happening. But I'm sure my colleagues in CHIPS would probably be able to tell you insight on that. My main question, though, or sort of to flag really, was there is a tension. You've mentioned ICBs and how the ICBs have got to wrestle with this, but actually the ICB footprint doesn't always fit for it doesn't fit for where kids are managed and the cross-boundary work that occurs, especially into Yorkshire. And I think so my question would be, I haven't read the whole report yet, but recommendations in terms of size and particularly the out of hours stuff. I think we do need to make a decision about how big our region is and how complex it is, with 3 children's hospitals, some very big and well-developed district hospitals, and how does it fit? And it may just not fit an ICB model. And that creates a tension because you're going to have work across the funding side. So I imagine if our ICB clinical leads, or not clinical leads, commissioning leads or senior responsible officers for children, perhaps that's the right word, it'd be really interesting to get their 4 opinions on this. That are they prepared to work together to look across those boundaries? Because the money issue will occur, but as well as the quality of service and the design of that service across those boundaries. So I don't know whether any of them are on this call, but if not, Yasmin, I guess it's how do we get out to those senior responsible officers and ensure that they're engaged with this work? Are they already on the page, or is that like the next step?
Thanks, Mike. Well, by a handy coincidence, the next hand up is Karen McNicholas from Humber and North Yorkshire, who covers into the North Yorkshire patch. Who's probably very well cited on this. Karen.
Hello everyone. Oh, crikey, here we go. Thank you very much, and wouldn't disagree with the points that's been made already. And I think we do need to think about this. What can we do together, and what does that region and what do the boundaries look like? I know we struggle with that as well, so I completely get that. I guess my point was, or the question I want to ask, the question of service specifications came up quite a lot. And just picking up on Lewin's comments, I'm just a bit concerned about the emphasis on that, if I'm honest, because when we spoke to our local providers, they said that they didn't want more resource into the team. They would rather work collaboratively with the hospices on this, and so would kind of emphasize Lewin's point really, because the other thing is, particularly if you're an area like ours, sometimes they might go a year without seeing a child who requires end-of-life care, and they didn't feel it could remain competent and competent. So, we can put it in the specs, and you can actually say, well, actually, could we provide any more resources? But the other thing they said as well is, if you give us extra capacity, that will get absorbed into the system, and when the need arises, they may well not be available to provide that end-of-life care. So I'm just thinking about Lewin's point really about how can you build on what we've already got rather than add something new. So it's just the service specification really, which is just making me think, because I'm rambling, but when we spoke to our providers, it wasn't something they said they wanted to do. If that makes sense. And I just wondered if they got that feedback.
No, we didn't, Karen. Sorry. Yeah. So no, nobody give us that feedback, Karen.
Right. Was a question asked, Nicola? It's just because I know I've had those conversations frequently, and it was something that they didn't want. So
yeah, it wasn't part of the CLOI. But like I said, we didn't just stick to the CLOI. We had general discussion, and I suppose if it wasn't asked as a direct question, maybe it wouldn't come out. I think it's probably very similar to some of the issues when I talked about the self-assessments and things. We didn't ask the question and it never came out. It was sort of afterwards, when you start reading all the literature yourself and then you start posing those questions, that we realise, well, no, some people had done it, some people hadn't. So very probably similar to what you're saying. But no, it certainly wasn't raised.
That's really helpful. Thank you. I just thought I'd clarify that because I was a bit puzzled. So thank you very much.
Yeah, no, absolutely, Karen. And I think it's one of those things that, and this is why it's so important that as systems go away and have discussions with all providers and other stakeholders in the patch. The other thing that we know, and I know our systems are already on with this, is that co-production of the service is really important as well, with families and with staff. There's no point of setting up services or the region saying you must do it this way if it doesn't actually meet the needs of patients across the patch, and it will be different, and that's okay. It's about how we meet the needs and flex to do that, depending on the services that we've got available. And some of this is going to be led by what workforce we've got available where as well, and how we can manage that flexibility. The issues around medical workforce are really well known, but we've got substantial issues around children's nursing workforce and the wider part of that as well. So ongoing issues. So I think we need to really value the staff we have firstly, and I think that is really, really important, and make sure we're using the skills in the best way. So I think, as Lewin said, that hospice partners have huge experience there, and their workforce are really able to give very specialist care, can really then support us in supporting staff who aren't necessarily delivering that care all the time, but they may want interim support or exceptional support and that kind of thing. And it's how we can get those flexible models to do it across the patch. The geography's challenging, shall we say, huge areas to cover, aren't they? So.
Yeah,
so
thank you. Thank everybody.
Thanks, Karen, and thanks to everybody. There is a lot in there to think about. Really happy to have more discussions. The network, can facilitate discussions, but I would actually say I think systems are really well placed to do this and have plenty of leadership and people in place who want to have those discussions. It's taking it forward and making sure that you feel you've got a broad range of people involved in that, and that partners feel like they're involved as well. Archana, you've got your hand up.
Hi, thank you, and thank you everyone, Nick and Simeon, for the report and the subsequent comments. Just a response to Mike's comment about the ICB footprints not being completely congruent with the services that are currently in place. And we see this as a tertiary hospital in Leeds all the time, because it's a West Yorkshire hospital, but the children who come to access tertiary services are from all over Yorkshire and sometimes from elsewhere as well. So and because that is the biggest tertiary hospital in the region, and therefore most of the complex children come there, and we have more deaths happening in the hospital, or even transferring out to the community for end-of-life care. That is a very tangible problem for us, especially as our service is funded by the West Yorkshire ICB. The question about how far do we go to support those children?
Thanks, Archana. And I think that's a really important question, and just emphasises that need for the system to be able to have that good communication and access across records and things like that. That's how we safely transfer care, isn't it? And those handovers. So I think that underpinning part is really key. Mike, did you want to come back in?
Yeah, no, just to say I totally agree, Archana. And actually the key to this, actually what added value, because in some respects you could say, well, actually the work's happening, let's just bumble along and let ICBs grapple with this individually. The whole point of doing this, I guess, is to enable us to find ways of coordinating and moving children around because of those geographical boundaries, and making sure that one service, ultimately, I guess we don't want to see the geographical variation of services which limits our abilities in one area depending on where you just happen to be born or live. So the hope is that actually we can create a reasonably equitable service, I guess, across the whole patch, but that then needs to be tied together in some communication structure. And it's got to be, it isn't just going to be NHS, it's going to be hospice too, but including actually being very clearly in what is NHS funded work. But the delivery of that could be different in each area. So it is a real challenge, this, I think. But I think it's a challenge as a network we have to sort of rise to, don't we? We've got to do it.
Absolutely, Mike. And I know Brie and I were talking to one of the hospices in the North East where they described quite a unique funding model for each of the patients that come in. That's a tripartite agreement between local authority, education and NHS. And there's different models. Some of them are less well spread and more difficult probably to negotiate now in times of funding crisis, I would say. But that doesn't mean we shouldn't be looking at them and looking at what we can do. And that's why I think the system bit is really important, because I think that the education and social care elements are really, really key. And I know certainly hospices tend to span all three of those areas and have those links as well. And we need to build on that. Diane, did you want to come in?
Julie White, I'm in with Diane. We're lead nurses for children and teenage and young adult cancers here in Leeds. I think one of the things that's putting me the hat on really is I was a community children's nurse and I set up the team in Harrogate in North Yorkshire. And so I'm really pleased to see that highlight of that investment within community teams. I remember, and again, it was quite a long time ago, you know, developing the Harrogate team was on the back of the New Opportunities funding. And the dictate at that time was very clear that the focus was on palliative and respite care. And we did provide that 24/7 predictive on-call, dependent on the numbers. And I think, you know, there is some real value in looking at how we invest in those community services that can actually provide that care closer to home, but with that support from, you know, the specialist services. So I'm actually quite, it was positive for me to see that on there actually. And I think what we found is that, yes, we do provide a 24-hour service, but we do have gaps in end of life care for certainly young people with cancer. And I think it's, oh, I've lost my train of thought there. That's but I think it's so we do provide that 24/7. What I was going to say actually, but interestingly enough, I think as we've seen a shift in community children's nursing services and maybe teams now coming within acute trusts and you know, being pulled locally into, you know, to help meet resource gaps, that actually, you know, we saw literally a 50% increase in our demand out of hours. And, you know, that's quite a hard, that's quite hard to buffer. So I think we absolutely value and, you know, working really closely with local services and community teams. So, you know, I think we'd be very interested in, Diane and I, anything that we can do to sort of link in and support, then obviously we'd love to be involved.
Brilliant, thank you. Thank you. And I think, you know, key in all of this and all the conversations I've had with various people is that everyone is actually centred on delivering care where families and children and young people want it. It's not that there is a specific model. It has to be right for that person at that time. And it's very different to the adult space, which was where I'd had any experience before as a GP, really. So I think there's a lot being learned, I would say, as we're looking at this on that bigger footprint. But there's some really good stuff already there. So as you know, as Lewin first said in this, we don't want to throw everything out, build on what we've got, and we make sure that if we can, everybody gets the best. And that's where our aim is for, isn't it? You know, we're trying to make it so that there's equitable access to really high quality services that people want, not trying to just say, well, we can't do it very well, so we'll just give everybody a bit of something that's as good as we can make it. Let's aim as high as we possibly can. So there aren't any more hands up, which could be because everybody feels very shy. Could be because it's been such an amazing presentation and the questions have just answered everything and put everything out there for people, but I will leave everyone to decide which that is. What I would say is this is not the end of a conversation, it's the start. Yes. So I think the next steps are into systems, supporting us, we'll support them. I think Julia Hackett is on the call as well, because there's going to be some ongoing work around evaluating services as well. We're very committed as a network to have ongoing research so we can have evidence for what works and what delivers the best care people want. So there's, you know, this is the start of the next step on the journey, I think. Mike, do come in.
as you know, I'm not shy, as no one else is putting their hand up. I was going to ask the urgency. During the review, are there any really, as well as being strategic, which is what this is about, and I totally support that because it is a complex system, new funding system. I mean, it is complicated, this, but are there any urgent things that are like kind of, we've got a huge big problem, and we just need to sort of prioritize or crack on and not, and try and take some more rapid steps? I'm very aware of the medical kind of cover issue as being somewhat urgent, but there may be others too that that Nicola's identified, and I don't know whether that's come out in the review. We've got to press the fast button on.
I think the most pressing bit that I got from it, Nick, was where we've got a very, very low or no community teams, and that for me would be the absolute priority. Each system will probably know where they are. I think if they don't, I think a rapid piece of work to identify that would be really sensible. But remembering that the community teams may be from hospices, they may be from social care, they may be from community trust. There's a whole variety. It's looking at all of them. What have we got, and how can we build on those and fill some of those gaps? I know I'm not going to name specific places, but places know where those gaps are, and that for me is the most urgent point, because if you haven't got a team, there's nobody who wants to get the advice. The families haven't got anybody supporting them, or they're having to travel very long distances and going out of area, etc. So that's the most urgent part for me. And then underpinning that, the other thing that I think is really key, and I'm not sure if urgent is the right word for it, because it's something people are already working on, but it is the digital interoperability piece and the connectivity between records that I think is really, really key. Like you say, things for families, things like getting a prescription changed out of hours is really important. And it might be a bit annoying when you're a doctor and you've got to phone somebody and somebody else, but the family is waiting for it and can't find the pharmacy. It's absolutely horrendous, isn't it? So those are the real drivers underneath it that underpin the whole system, I think, are really key as well to start working on, because we can't move to the next bit without them. But yeah, I know you're not shy, Mike. Oh, Marie's not shy either. Excellent. Come in, Marie.
No, I'm definitely not shy. I've just had a couple of emails come in. People are asking me for the report. If you go to the top bar where it says Q&A, click on there, and we've put the link in there several times now. So it's on our website, and next to it we've also put the new national guidance for 24/7, which came out last week. So please have a look in the Q&A. The link should be there. If you're still having issues, then do email me again, but I've just seen a few emails come in, so thank you. Thanks, Yasmin.
Thanks, Marie. Yeah, and just to say, have discussions in systems. If people don't know who they should be linking with, just get in touch with us. More than happy to do some connecting up and facilitate support whenever we can. Really happy to do that. We will be carrying on as the clinical network with clinical leads and looking to support this as much as we can. But I might suggest we give everybody 3 minutes back of their day